Look, if you're a first-year medical student just starting your renal block, I know exactly what you're feeling right now. Overwhelmed? Yeah. The sheer volume of information can literally feel like a nightmare. Rote memorizing renal drugs, trying to keep all those transporters straight. The side effects? It's exhausting. But welcome to this explainer, because today, we're going to fix that. We're going to build a logical framework that will completely change how you study the kidneys.
So, what if I told you there's a cheat code? What if understanding just one tiny microscopic structure, the functional unit of the kidney, is the master key to all of this? If you can visualize this one single structure, you can actually master kidney physiology, blood pressure regulation, electrolyte balance, and pretty much every major diuretic drug you'll see in pharmacology. Stick with me here, because we are going on a conceptual journey right down to this cellular level. And this brings us to the absolutely crucial point of this whole thing: logic over memorization. Seriously, the biggest mistake students make is trying to brute force memorize drug locations and side effects without having a clue about the underlying physiology. It just doesn't work. But once you understand what the baseline physiology does first, the pharmacology becomes this incredibly easy, intuitive consequence. It just makes sense. We're going to make this so simple, you'll literally never forget it. Okay, here's our roadmap for today's explainer. We'll kick things off with the nephron and glomerulus, move on to the proximal convoluted tubule, dive down the loop of Henle, head back up to the distal convoluted tubule, finish our trip at the collecting duct, and then wrap the whole shebang up with a high-yield rapid revision.
All right, part 1, the nephron and glomerulus, also known as the factory filter. Let's get into it.
Picture this: you're just a single drop of blood entering the kidney. You are about to enter an incredibly efficient recycling factory. You have about 1 million of these functional units, called nephrons, and they are doing massive amounts of work, 24/7, to maintain homeostasis. We're talking filtering your blood, pulling out waste products, maintaining water balance, keeping your electrolytes strictly regulated, balancing your acid-base levels, and controlling your blood pressure. It is a massive, life-sustaining workload. Now, the very first stop in this factory is the glomerulus, which is basically just a tiny network of capillaries. Blood enters this filter under high pressure, and that pressure pushes water, sodium, glucose, amino acids, and waste right through the membrane and into Bowman's capsule. Larger stuff, like proteins and blood cells, they safely stay behind in the bloodstream. And this brings us to a really critical definition you need to know: glomerular filtration rate, or GFR. It's simply the amount of fluid filtered every minute. Clinically, it's one of the single most important scorecards for a patient's kidney function. Okay, pause. Before we move on, I want to cement a core physiological rule in your brain. The glomerulus mainly filters. That's it. It does not significantly reabsorb, and it doesn't secrete. It has one job in this factory, and it does it exceptionally well. Keep this baseline rule isolated in your mind as we move forward. Moving right along to section 2, the proximal convoluted tubule, the major recycling center. Leaving that initial filter of the glomerulus, the massive task of bulk reabsorption kicks into high gear, 70%. I want you to remember that magic number for the PCT. Approximately 70% of all that filtered sodium and water gets reabsorbed right here. And on top of that, almost all the filtered glucose and amino acids are reclaimed and sent right back into the body. The sheer volume of work done in this first tubular segment is honestly staggering. So now that we know the physiology, watch how the pharmacology makes perfect sense. Let's look at the clinical interventions acting on the PCT. First up, carbonic anhydrase inhibitors, like acetazolamide. Because the PCT reabsorbs so much, these drugs work right here to block bicarbonate reabsorption, basically forcing its excretion. Very useful for things like glaucoma, altitude sickness, and certain metabolic disorders. Second, we have SGLT2 inhibitors, like empagliflozin. Since the PCT normally reclaims all your glucose, these drugs block that exact process, forcing the glucose to leave the body in the urine. This has been a real game changer, not just for diabetes, but for heart failure and chronic kidney disease too. Next up, section 3, the loop of Henle, where we create that all-important concentration gradient. As our little drop of filtrate plunges down into the loop, we see this really elegant system of opposites. The descending limb goes down and allows water to leave, which makes the filtrate super concentrated. But then it turns the corner. The ascending limb goes up, and it's completely impermeable to water, totally waterproof. Instead, it actively pulls out sodium, potassium, and chloride. These opposing actions between the two limbs, that's exactly what creates the necessary concentration gradient deep in the kidneys so we can actually form urine. So how do we target this with drugs? Simple. We map the pharmacology directly to that ascending limb physiology. Enter the heavy hitters. Loop diuretics, your furosemide, bumetanide, torsemide. These drugs specifically block that sodium-potassium 2-chloride transporter in the thick ascending limb. By blocking the reabsorption of those electrolytes, sodium and water get trapped in the urine, causing powerful diuresis. This is exactly why we use them for patients dealing with heart failure, pulmonary edema, hypertension, or any kind of severe fluid overload. Actually, I want to pause here for a really direct, high-yield board review tip. If you take nothing else away from this section, remember this exam pearl. Loop diuretics are the most powerful diuretics you'll study, period. Because they block reabsorption at a site that normally handles a massive amount of sodium, the diuretic effect is profound. Make sure you anchor that clinical importance in your mind. All right, heading back up towards the cortex, section 4, the distal convoluted tubule, where we fine-tune those electrolytes. So now our physiological job shifts from bulk lifting to fine-tuning. When we apply pharmacology to the DCT, we get thiazide diuretics. Classic examples here being hydrochlorothiazide and chlorothalidone. Their mechanism is super straightforward. They just block those specific sodium chloride transporters in the DCT. Because there's less sodium being reabsorbed here compared to down in the loop of Henle, the result is a much more moderate diuresis. But here's the kicker. Remember, the DCT also handles calcium. While thiazides block sodium, they actually increase calcium retention, which makes them perfectly suited for treating hypertension while also preventing calcium-containing kidney stones. 2 birds, 1 stone. Which brings us to another explicit, extremely common exam question for first-year med students. Which diuretic increases calcium reabsorption? The answer, always thiazide diuretics. Solidify this unique relationship in your head right now. The DCT, thiazides, and calcium retention. They all go hand in hand. Almost done with our road trip. Section 5, the collecting duct, making the final adjustments. At this final stop on our anatomical journey, the physiology is heavily dictated by hormones. They run the show here. Let's clearly differentiate the 2 critical ones operating at the collecting duct baseline. First is aldosterone. Its main job is to increase sodium absorption while simultaneously kicking potassium out, so increasing potassium excretion. The second hormone is ADH, or vasopressin. ADH simply increases water reabsorption, making the final urine more concentrated. These 2 hormones work together to determine the ultimate composition of the urine based entirely on what your body's hydration and blood pressure needs are at that moment.
Naturally, the drugs acting on the collecting duct are called potassium-sparing diuretics. They work by directly antagonizing this baseline hormone physiology. Drugs like spironolactone and epleronine specifically block those aldosterone receptors. Meanwhile, amiloride and triamterene just block the sodium channels themselves. By blocking sodium reabsorption here, they cause mild diuresis. But crucially, because they disrupt aldosterone's normal action of excreting potassium, these drugs make the body hold on to potassium in the blood. This is why you absolutely must stress their major adverse effect, hyperkalemia. Whenever you hear potassium-sparing diuretics, immediately think red flag, dangerously high potassium levels. Finally, section 6, high-yield rapid revision. Let's lock all this in. All right, it's time to pull it all together. Let's prove how much you've just mastered by running through this micro-journey one last time, step by step. Step 1, glomerulus. What does it do? Filtration only. Step 2, the PCT. It's your major reabsorption center. Acetylzolamide blocks bicarb here, and SGLT2 inhibitors block glucose. Step 3, the loop of Henle. It creates that concentration gradient. This is exactly where your most powerful drugs, the loop diuretics, go to work. Step 4, the DCT. It's all for fine-tuning. Thiazides act here, giving you moderate diuresis but retaining calcium. Step 5, the collecting duct. It's under hormone control by aldosterone and ADH. Potassium-sparing diuretics act here, but remember, watch out for hyperkalemia. Seriously, if you can remember this basic sequence, you have completely conquered the foundations of renal pharmacology. Look, the big takeaway here is that as a medical student, you shouldn't just be memorizing the nephron. You need to visualize it. Think of it like a journey where every segment has a unique physiological job. When you do that, the pharmacological targets become completely logical. No more rote memorization. Now that you've unlocked this framework, I want to leave you with a quick choice for your next study session. What should we tackle next in this explainer series? Should we dive into the renin-angiotensin-aldosterone system? Tackle the fun complexities of acid-base balance? Explore these diuretics in even greater detail? Or jump straight into renal pathophysiology? The choice is entirely yours. Keep visualizing, keep learning, and I'll catch you in the next explainer.